Once again, welcome everyone. Good afternoon, good morning. Welcome to the 11th parallel session of first conference of Jindal School of Government and Public Policy, annual conference on economics and public policy. This session is about public health, and in this COVID time, we have seen a lot of life-changing things happening around public health, so many deaths in around the world, so much of crises, and what importance public health has and how it can affect the whole economy of the world. We have seen it was a pandemic of unprecedented scale. So we need to discuss public health issues more critically among the policy circles, but we have also realized that public health is not only about a vertical discipline. It needs to, the discussions of public health has to be multidisciplinary. It has to get insights from various social sciences, at the same time biology, medicine, not to discount other, in fact, information technology. So there are so many aspects that are there to understand public health better. And with that spirit, we have our session of three very distinguished, very sincere academicians working on issues of various issues of public health. And we'll talk about the health of the elderly people. We have Cristina Prieto from University of Murcia, Spain. We have Namita Mathur, who would map out the health sector initiatives, outcomes, and financing in the last 2 decades in the country. And it's very important to study this thing systematically, the developments of health policy systematically. So Namita would bring some of her insights into it. We have Anupam Tyagi, who will talk about the gender gap in the desired body mass index in US, based on not only for various age groups, incomes, and race and ethnicity. My apologies. So roughly, if we think about logistics of the session, the basic rules, I think we'll, is it okay if we go by the order that is there on the schedule? In the sense, Cristina going fast, Namita following her, and then Mr. Tyagi. Is it okay to all of you?
Yes, it's fine.
Okay. So we roughly have 20 minutes for each of the presentations, and probably 10 minutes each for discussion. I would suggest that we take the discussions towards end, try to bring the various aspects together and have a more conversation towards the end. But if people have any immediate comments, any clarification, I think we can still take those. I had asked our panelists to, if they are okay with that idea, and I think all of you are fine. It may be the case that we have to ask each other as questions, and let us take it more informally and in the form of discussion. So with this, I have already taken 5 minutes. So I'll request Cristina to start her presentation. She's going to talk about downsizing after a health shock at old age in Europe. Welcome, Cristina.
Thank you very much. So, greetings from Spain. I'm associate teacher professor at the University of Murcia, which is a city in the southeast of Spain. And I've prepared this paper with the collaboration of Professor Joan Costa-Font, which is currently at the London School of Economics. So for the case of European countries, we face 2 challenges. First, that older people, they prefer to remain living at their own homes when they get older and receive the necessary amount of long-term care services. So from the point of view of public policies, first, they have to prepare the necessary or provide the necessary amount of long-term care services, community services mainly, but at the same time, they afford the challenge of providing the necessary space for new families or younger generations. So today we still know little about the behavioral motivations of individuals for downsizing decisions. If we do a brief review of literature, there are different definitions proposed for downsizing. We are going to focus on a broad definition. So downsizing is going to include both the decrease in housing stock and the reduce in the size of dwelling. So first of all, a household with lower value as compared to total amount of wealth, and second, a smaller house with less number of bedrooms because adult children are out of household, so we only have the older couple or just one of the surviving members of the couple. So regarding the motivation, the theoretical motivation for this paper, at least in European countries, we are living in circumstances of overconsumption among older generation. That is, for example, in the case of Netherlands, we have among individuals between 60 and 69 years, usually they live in a situation of empty nester stage. So they have a higher amount of space or resources, household resources than they need. So this is going to give rise to a bottleneck in the housing market. What is the underlying reason? Well, perhaps older people expect to use this housing asset as a safe insurance in case of need. What type of need? Mainly the case of a health shock. So most of health shocks are sudden. They can be categorized as sudden negative life events. And some studies have found that those individuals who move after a health shock, they experience an average decrease in home value of about $26,000 as compared to those who move without a health shock. We have experienced an average increase in home value of almost $33,000. So, but at the same time, we have to be prepared that health shocks can also inhibit downsizing decisions if they signal uncertainty on future medical expenses. So housing can be considered as an asset of last resort that will only be used in case of having the need to pay for nursing care or to support the surviving spouse. So the role of the spouse of partner is going to be considered also in this paper because we think that is rather important. Regarding the data, there is an important survey that has a European coverage, the survey of health, aging and retirement in Europe, and we are going to focus on the period from 2004 to 2015. The initial sample has 160,000 observations. We are going to build a panel data sample which has 33,000 observations corresponding to 6,700 individuals. We appreciate in the red column the percentage of individuals who have reported changing of residence between two consecutive waves, which is the highest one in Sweden, 10%, followed by Denmark, 9%. So it's clear that the number of observations has been reduced drastically due to the construction of the panel data. So briefly, we have performed some attrition tests to confirm that attrition is random and it's not going to bias the results for the remaining sample. So we are going to consider the following variables. Change of resident, if the individual has change of resident between two consecutive ways. The ratio of home value with respect to total wealth, and there you have the definition of total wealth. Also the ratio of mortgage to home value ratio, that is mortgage divided by home value, and the difference in the number of rooms for those individuals who have change of house between two consecutive waves. We also consider three types of health shocks. One referred to non-mental illness, another referred to mental illness, Parkinson, Alzheimer, depression, and shock for activities of daily living, you know, dressing, bathing, cutting of your food, getting in out of bed, etc. As I said before, we also consider the health shocks of the spouse of partner and the health status at baseline. We include a vector of sociodemographic characteristics, and also it's important that we have information regarding the region of residence, with that the European definition, they are called NUTS level. So we are going to introduce fixed effects for region. In this picture, we observe the percentage of individuals who have moved between two consecutive waves. The black line and the green line correspond to the last waves. So it's clear that as individuals get older, the probability of having change of house increases from around 4% to 8%. Also, which is rather consistent, is that the probability of having suffered a health shock, whatever type of health shock, increases for all waves as individuals get older. In this map, we appreciate the following facts. First, the red areas correspond to the percentage of households who have moved to a house with a smaller number of rooms. So the decrease in the number of rooms is higher in Italy and France. The purple bricks denote the percentage of households who have moved to a house with a lower value with respect to total wealth. And this is clearly larger in Germany, in Sweden, in Denmark. And the green circles, the percentage of households who have reduced the ratio of mortgage with respect to home value. And this is higher, for example, in Switzerland, but is almost non-existent for the case of Spain. So in this table, we observe the distribution of households regarding tenure, and also the tenure before and after change of residence. We appreciate that homeowners are the less likely to change of residence, 5%, as compared to tenant or subtenant, almost 11%. And also that around 80% of those who change residence have suffered a health shock, choose to keep the same tenure regime. For example, for those who were owners, 84% remain owners after the health shock. For those who are member of cooperatives, 80.70%, with exception or rent-free individuals. So in our econometric models, we are going to consider the potential endogeneity of health shock for the decision of having change of residence, and also the endogeneity of change of residence in the equations for home value. So we propose the following instruments. In the first case, lifestyle instruments, being a smoker or former smoker, being obese or overweight, regular alcohol consumption, and sedentary lifestyle. For the housing market, we include the cooling and heating degree days, the housing price index, and the growth rate of housing price index, and the number of daughters at home. So briefly, there is evidence that there is an increase in mobility for older Americans, although our paper is focused on European countries residing in colder areas who seem to be more likely to move to warmer areas. Also, lower house prices lead to lower household mobility, perhaps because people are more risk averse and they know what to sell per property for less than they want before. So I'm going to propose 3 different models. This is a preview of the models. So the first one is for the change of residence. So C star is the variable, the latent dependent variable for having change of residence, is a function of C time minus 1, the change of residence in the previous period. SH is the health shock of the respondent and also health shock of the partner. We include a term capturing unobservable heterogeneity, and finally an error term. We estimate this model using Woolridge conditional maximum likelihood estimation because it allows for correlation between unobserved heterogeneity and explanatory variables. And we are also going to introduce the potential endogeneity of having suffered a health shock, perhaps because people are more susceptible to suffer health shocks if they live in poorer housing conditions. In fact, in this graph, each point represents a European region, and we appreciate a positive positive correlation between the percentage of individuals at regional level who have suffered a health shock and the percentage of individuals at regional level who have change of residence. So instead of a pure random effects model, we propose a dynamic correlated random effects model following the MODERATOR approach. First, we experience a regression for the potential endogenous variable using the proposed instruments. We obtain the residuals and the average for each individual, and we introduce the residual in a final probit model for the probability of having change of residence. Now, for the home value and mortgage to home value, they are fractional variables that they take values between 0 and 1 because both of them are ratio. So we follow the model proposed by Kapke and Woolrich, but additionally, we consider that the variable change of residence may be endogenous. So we introduce the proposed 5 instruments and estimate the final model by quasi-maximum likelihood. And finally, for the difference in the number of households, evidently, this is a variable that takes values -1, -2, 0, +1, +2. So we are going to consider that the variable C, change of residence, may be endogenous. So apart from the health shock of the responder and the partner, we introduce, as before, the instruments for having change of residence, and we estimate a 2-stage GMM using the instruments proposed before. Regarding the results, first of all, the first stage estimation for health shock. We appreciate that being obese, overweight, or having sedentary lifestyles are the main forces determining the probability for suffering any type of health shock. Now, using these estimations, we introduce them and obtain the probability of having health shock. And in this table, we compare considering health shock treated as exogenous in the left part, considering health shock treated as endogenous. So in the green rectangle, we observe that health shocks are found to be positively associated with the probability of changing residence. In the red rectangle, we appreciate that the probability of changing residence increases if one has suffered a health shock, 10 percentile points in case of mental shock, 6 percentile points for shock of instruments, activities of daily living. Additionally, the probability of changing your residence decreases 2 percentile points for every 10 years of life. However, the interaction, and this is in the blue rectangle, between age and health shock is positive and significant, 2.6 percentile points for mental shock and 1.3 percentile points for ADL shock. We also observe that the lag coefficient of change of residence, which is highlighted in red, denotes a strong persistence in housing mobility, both in pure random effects and in correlated random effects. The reduction in the delayed change of residence when comparing pure and correlated random effects, that is the left part and the right part of the table in the first line, denotes that unobservable heterogeneity introduces a considerable upward bias. And finally, highlighted in yellow, the significance of the coefficient associated with the initial value denotes a significant correlation between the unobservable effects and the initial condition. We also observe the same pattern of behavior for spouse of partner, so they are also important in the decision of moving home. Although age has a negative effect on mobility, the interaction of age combined with a health shock is also positive and significant for the case of partner or spouse. Now for the ratio of home value with respect to total wealth. First, the instrumental variable estimations. We have introduced heating and degree days, cooling degree days, housing price index, growth rate, housing price index, number of daughters. We appreciate that all of them are significant, and I highlight that the presence of daughters at home is very important for the decision of changing of residence, in this case with negative effect. So instrumental variables are validated, and now we turn to the effect of over home value with respect to total wealth. We observe, first of all, in purple color, that change of residence increases this ratio. This is a first important result. Previous ADL shock increases the ratio by 3 percentile points, and in case of mental shock by 2 percentile points. This is highlighted in red. In green, new health shocks are associated with an increase in the ratio of home value with respect to wealth. However, and this is important, the combination of change of resident and health shock is negative for any type of health shock. Minus 9.7 percentile points for mental health shock is the most important result. So in this case, people who move after suffering a mental health shock, they experience a decrease in home value with respect to total wealth. Same results for health shocks and combination of health shock and change of residence are observed for partner or spouse. Now we turn to the results for the ratio mortgage with respect to home value. We appreciate that change of residence and health shock present significant differences between the fourth specifications and the previous one. Here we have the oldest piece effects, fractional profit with quasi-maximum likelihood estimation, fractional profit EA, and fractional profit with full generalized maximum likelihood estimation. Changing residence increases the ratio, and it also increases when suffering an ADL shock, mental shock, and non-mental shock. However, moving house and having suffered a health shock leads to decrease, so people decrease the amount of mortgage that also have to pay by 5.2 percentile points. In this case, this is the most important health shock for ADL, minus 4.7 for mental shocks, minus 1.3 for non-mental shock. Same results are observed for partner or spouse. Finally, for the difference in the number of rooms, and this is quite curious, the change of residence, so people who change from one house to another tend to increase slightly the space, plus 0.11 rooms. However, if the individual or the partner has suffered a shock of ADL and has change of residence, the new dwelling has between minus 1.1 and minus 1.05 fewer rooms. So in this case, the space decreases. And if they have suffered a mental shock, the new dwelling has approximately half a room less. So these are the rectangles highlighted in red and purple respectively. Finally, we appreciate important differences by countries. For example, the probability of having change of house is important for Denmark, Spain, and Sweden. However, when they have change of house, we observed that the variation in home value with respect to total weight decreases the most for Sweden. For the case of Germany, very, very important, minus 30 percentile points in case of mental shock, and Denmark. For Spain, the probability of having change of house is important, but the variation in home value is not such important. We also appreciate a decrease in the value of mortgage with respect to home value in Denmark, Sweden, Switzerland. And finally, the reduction in the number of rooms is also important in Germany, minus 3 rooms for non-mental shocks. In Sweden, for mental shocks, minus 2 rooms. And in Denmark, for the case of ADL shocks, minus 2.6 rooms. Finally, the conclusions. We have highlighted that the onset of mental illness or new limitations in performing activities of daily living increases the probability of changing residence with an additional age effect. Individuals move to lower value dwellings with lower home value and lower ratio mortgage to home value. So according to predictions for the next year, there is going to be a significant increase in mental illness. So at least from the point of public policies, they should be prepared to provide the necessary alternatives. And I would like to focus the attention to co-housing that is more developed in Northern European countries, but not in Southern European countries, which is another model different from institutionalization. So, or a second alternative is the adaptation of current dwellings to the future needs, and also evaluate the potential impact on urban and rural areas, because at least in the case of Spain, we are suffering a problem that the countryside is almost suffering a severe depopulation. People are moving to the cities. So that's all. These are our email address if you want to make any question or suggestions. And thank you very much for giving me the opportunity of sharing these results. That's all.
Thank you, Cristina. It was a very interesting, insightful presentation. While in many of the developing countries, when we think about health shocks, we think about the financial protection aspects, and some other dimensions of welfare effect of health shocks are often ignored. And your paper clearly brings out that in a context where some of the financial protection aspects are taken care of, still health shocks bring about changes in the lives of elderly people. The case here is the change in their housing, and your policy suggestions are very important, particularly for the Southern European countries.
Yes.
Thank you so much. Hopefully, towards the end of the presentation, we'll take more observations and discussions.
Thank you.
Let me now invite Namita Mathur from University of Delhi. Namita's paper is a mapping of health sector initiatives, outcomes, and health financing in India since the 2000s. So we have seen a lot of changes in the health policy in this period, and we look forward to hear from your insights about this. Namita, over to you.
Thank you, sir. I'll just share my screen. I hope my screen is visible to everyone. Is my screen visible?
Yes, please go ahead. Yes.
Okay, all right. Okay, my topic, as just told everybody, is a mapping of health sector initiatives, outcomes, and financing in India since the 2000s. Yes, I don't. Okay, so basically the objectives that I have from this paper were that I was trying to show some of the inequalities. I've been more inclined to show the inequalities that are there. I've particularly concentrated on the urban areas in India. The study is basically based in India, and I've also tried to look at some of the inequalities that are there in our country, which is in India and in urban areas in particular, because a large section of urban areas comprises of the urban poor or the urban marginalized sections of society. So I think it's more relevant for us today to see how inclusive are the health sector policies for the marginalized sections, because the well-off anyway get the best medical care in any case. So it's basically the marginalized sections whose health needs are pertinent to be looked at carefully, or to see how inclusive our policies have been. So I've tried to highlight some of the inequalities that are there plaguing the health sector today, since the 2000s, of course, based on some of the policies that have been there since then. Then though there have been a lot of central and state level policy interventions in the area of health, all the policy interventions, of course, aimed at providing inclusive access, equitable access to healthcare facilities to a large sections of the population. Yet my study has shown that there are rising levels of inequalities in the country when it comes to health outcomes, whether it's healthcare financing or just indicators such as life expectancy, maternal mortality, child health, etc. And when we look at the different income quintiles, which is what I've tried to look at in detail, we find vast inequalities in the access of different income quintiles to the health facilities in the country. And this is another aspect in healthcare financing is also when we look at the public expenditure that's been made on health by both the center and state, and how there's also been very high out-of-pocket expenditure for households, which clearly is not met by any policy, which is not covered by any policy. So these are some of the key aspects that I would be touching upon in my paper. Now, as rapid urbanization, because as I mentioned earlier, I'm dealing basically with urban areas. So with urbanization happening at a very rapid pace in the country, especially in the last decade or so, 2 decades, there's been a substantial proportion of the people who have moved to urban areas or who are living in urban areas comprises of the urban poor. And many of these people live in slums, they live in squatter settlements, they have very limited access to the basic civic amenities that one requires for a decent level of living. So they don't have access to clean water supply, sanitation, health, nutrition, education facilities for their children. So the very basic services, something that we people take for granted, are not there for them. They don't have equitable access to those. And this is where some kind of policy intervention is required to ensure that all sections of society, of the people who are living in these areas, have inclusive access to them. Everybody has equitable access to them. When we look at just GDP numbers are clearly increasing. We've had high GDP growth rates in the country, but just having high GDP growth rates does not always ensure that everybody is actually able to achieve the benefits of that. The acceptance of the trickle down effect, that if GDP growth rates are high means that all sections of society are doing well, is something that we really shouldn't be taking for granted. And even though there has been a lot of social sector spending by the government, and the idea of social spending has always been that the productivity of the population should go up, provide them with better health, education, facilities, urban development, water, etc. Yet it has not happened. And again, when we look at the social sector here, having policy intervention is relevant, because if the social sector is given to the private sector, or if the public sector reduces its share in that, then there is a problem, because there's always a possibility of under provision if the social sector is simply left to the private sector. So that is why, if we look at the policy trajectory also, since 2005-6, the focus of all poverty alleviation strategies has been more on rights-based approach, whether it's a right to employment, right to food, right to everything. I mean, whether like even recently the right to having a toilet or the Swachh Bharat, I mean, it's more of a right-based approach that has now come in place since 2005-6. So the focus of poverty alleviation strategies has been on such kind of a strategy for poverty alleviation, where everybody should have a right to clean air, people not clean, right to water, right to education, etc. And there have been many changes similarly in the healthcare sector as well after that. So whether we've looked at education, food, as everybody knows, but even in the healthcare sector, there has been a focus on providing universal healthcare for all sections of society. And if we look at the data for health, the outcomes, we find that at an aggregate level, there has been a clear improvement, whether it is life expectancy, infant mortality, neonatal mortality, or under 5 mortality, maternal mortality, etc. There has been an improvement in aggregate health outcomes, but yet there have been very vast inequities. At the same time, there's been a lot of inequitable development in the sense in health, at least in health outcomes. There have been wide disparities between the urban poor and the economically weaker sections of, and the economically better of sections of society in the cities in particular. So the disparities of the access to these healthcare facilities has been widening for the two extremes. If you look at the poor, their access as compared to the access of the economically better off, the gap between them has been widening over time. India has seen 3 national health policies in 1983, then 2002, and the most recent one in 2017. The basic focus of these national health policies, at least NHP 2017, was to have better health status, program back to have better health utilization of better health, public health services, also to strengthen the health systems, whether it's health finance, health infrastructure. These have been the primary goals of the national health policy, the most recent, the 2017 one. And as part of the NHP 2017, there was the Ayushman Bharat Yojana has been there. There's been Pradhan Mantri PMSSY RSBY, which is for insurance, and many other schemes as well. Now, when we look at these schemes, these are some of the policies to improve health outcomes in terms of life expectancy, etc. There have also been policies which have aimed at healthcare financing, because healthcare financing is an equally important concept. Financing, because a lot of marginalized households, the problem that they face are that they do not have funds to provide themselves or provide their families with adequate healthcare facilities. And this is where health insurance schemes come in, or the role of health insurance schemes becomes very important. Many of these schemes, of course, financed by individuals themselves. Many of them are provided by employers. The contributions, of course, pooled together. to purchase the scheme from either the government or a private provider. So the various, of course, kinds of health insurance depending on how it is being financed. Now, this is what the policy focus has been till now, whatever I have explained. These are basically some of the policy schemes that have been designed to provide better health facilities to a substantial part of the population. The next aspect of our study is on the health outcomes. That once these schemes have been put in place, the policies are there, what really needs to be seen is how successful have these policies really been in meeting the needs of all sections of society. Have these policies actually been inclusive the way they were intended to be? And to see the success of these policies, one needs to analyze health outcomes. So here for this, I've used data from 2 rounds of NSS, the 71st and the 75th round, and also National Family Health Survey 3, which is 2005-6, and National Family Health Survey 4, which is 2015-16. I've tried to do a comparison of these survey rounds, of course, comparing NSS rounds with each other, NFHS rounds with each other, to see how there has been a progress in health facilities for different people. And here, now when we look at the urban poor, why is health for them so important? Is that if we look at the cost of medical care, for them, it is not just the explicit cost which we see in providing medical care. Another important aspect is the loss of income. Because for them, when you're earning daily wages, a day that a person spends in a hospital for either his or her own health or the health of a family person or someone in the family means loss of income for a day. So for them, actually, there is a double cost of medical care, not just the medical expense, but also the loss of income. And this is one reason that is kind of limiting their access to health facilities. If we look at a healthcare delivery, so there are different aspects of outcomes that I've looked at. The first one is healthcare delivery. So here we find that 70% rural population and 80% of the urban population was dependent on private healthcare providers in the 71st round. In the 75th round, these figures went down partially from 66 to 66.5 and 72.5. Now, private healthcare providers is actually a very heterogeneous group. So on the one hand, we have multi-speciality or super speciality hospitals providing the best of medical care facilities. On the other hand, a lot of slum areas also have medical practitioners with dubious qualifications who again come in the category of private healthcare providers. So when we look at data and we look at private healthcare providers, it does not always mean that someone's going to some very fancy or super speciality hospital where he gets the best of care. It could also mean a local doctor who's probably just a quack and just giving some medicine which may not even really help the person. So that is why a very large section of the population dependent on private healthcare providers is something that needs to be really taken with a pinch of salt to see whether they actually have access to decent medical facilities or not. The next outcome that I've looked at is hospital healthcare coverage. So whenever some family member is hospitalized, there are of course a lot of expenses that have to be borne. A lot of it, sometimes the idea of health insurance is that these expenses need to be covered by insurance. And NFHS 4 has actually shown a very positive picture over here with an increase in the coverage of health sector schemes. And a lot of insurance coverage also has increased when we compare it to NFHS 3, which we can see over here that the percentage of households with even one member covered by health insurance increased from 4.8 to 28.7% in a 10-year period. And maybe it's also reflective of the RSBY, which is an insurance scheme by the government. So it is also likely that because of the success of this scheme, health insurance coverage has probably improved in the country. But here again, we are looking at the averages. If we compare for different income quintiles in the health expenditure support, the picture is a little different. So we see in the lowest quintile in the 75th round, which is 2017-18, only 9.8% of the people in the lowest income quintile in urban areas in the country had access to any health expenditure support. Whereas if you look at the topmost income quintile, it was 33%. And if we compare the 71st and the 75th round, we don't even find a narrowing of this disparity between the different income quintiles. So while averages, of course, show that it went up from some 4% to 28%, if you look at the different income quintiles, we realize that disparities are there in actually this health insurance. And if you look at the reason for this coverage, of course, a lot of times the urban poor or the poor in general are not even aware of the schemes. And even when they are aware, that's beyond their reach. They really don't know how they will be able to actually have access to those schemes. And when, of course, they don't have any insurance or any such cover for their medical expenses, then ultimately they have to either liquidate their assets or they resort to borrowing, which again pushes them into a poverty trap. And here also, even if they are covered by any insurance, even then the amount of medical expenditure that was actually reimbursed to them as a percentage of the total expenditure, we can see over here also, it was only 4% for the lowest quintile. For the highest quintile, it was almost 27%. And if we look at cities like Delhi, where there's a lot of migrant, urban, poor population, we find this disparity is even more stark, where 3% in the lowest income quintile having, 3% of the medical expenditure for the lowest income quintile being reimbursed, but for the highest, it was 50%. Then if we look at the sources of financing for any hospitalization expenditure, here again, we find disparities where a lot of course, the lowest income quintile people, as we can see in the 75th round also, they had to resort to borrowing or some contribution from friends and they had to borrow. Whereas for the highest income quintile, simply their savings and all were enough for them to finance their expenses. Then we see maternal healthcare coverage. So again, at the aggregate level, it's a very positive sign that while institutional births were only 38.7% in NFHS3, the percentage of institutional births went up to almost 79% in NFHS4. But if you look at the Janani Suraksha Yojana, which provides financial assistance for having institutional deliveries, we see that only 36% of the mothers actually received some kind of assistance under this scheme. And again, when we do a contrast between the poorest and the richest, when we look at maternal healthcare coverage, here again, there's a disparity where 15% of the urban poorest had a delivery at home, whereas for the richest, it was 3%. And it actually went down to 0.8% for the richest in 2017, while for the poorest, it was still 7.8%. And in the case of cities like Delhi, this disparity is even more. They have wide differences. And this is, of course, a cause of concern because even today, maternal mortality rates continue to be high, which is a cause of concern. Maternal and child health is something that's really a cause of concern and an important aspect of the National Health Mission as well. If we look at, again, figures of those who've had deliveries at home, when we're looking at maternal health, we find if at the all India level as well as in Delhi, for the 5th quintile, it has, even if they've had a delivery then, there's a very, very minuscule population which was actually having a delivery at home in the highest quintile. In Delhi, it was, of course, 0. Whereas in the lowest quintile, it was still a substantial percentage that was having a delivery. And with no doctor also, then things become even worse in terms of having high maternal mortality rates as a result of this. Now, the next section of the paper deals with health expenditure. So we've looked at the health policies, we've looked at the dismal health outcomes if we analyze different kinds of income quintiles. The next part of the paper also needs to look at, I've tried to look at whether the policies clearly in many cases we have seen are not making a desired impact, at least for the marginalized sections. So now we need to see where is the problem. Is it that the expenditure is not adequate? So here I've tried to analyze what are the ways of financing health expenditure, what should be the ways, how should they really need to be allocated in an appropriate fashion, and how can the out-of-pocket expenses be reduced for the marginalized or the people in general. So key question that I've tried to answer over here is if public expenditure on health is commensurate to the requirements of inclusive growth for urban population. So here again, public expenditure on health, both by the center and the states, has been low.
Namita,
and even, yeah, sorry,
unfortunately, you have I think 2 more minutes, but if you can
Okay.
wrap it up in 3-4 minutes, that would be
Yeah,
great.
I'll do that. I think it's just a small portion. I'll quickly go over it. Yeah. So the total allocation for the health expenditure has been, of course, below. The NHP demanded that it should be 2.5% of GDP, but it has been below that. The union government ideally also should be spending at least 40% of the public expenditure. That again has not happened. The states have been spending much more, but even after that, the states, the latest record are only spending 1.1% of the GDP on health. If we look at the allocation for various schemes, the National Health Mission, etc., here again, we find that in the last 2-3 years, the allocation for NHM was almost going down, even in absolute terms. And in percentage terms also, the National Health Mission, it has actually been going down. It went down from 64% of the budget to 49.6% of the budget. An important component of National Health Mission was reproductive and child health. And as we've just seen in data, the figures were not very positive for maternal health as well. So that's why a decline in the allocation. There's also been a decline for the RCH program, reproductive and child health program, which is again a cause of concern because maternal and child health are very key aspects of health for any country. The allocation, on the other hand, for schemes like PMSSY, PMJY have been increasing, which is of course laudable because they provide improve health infrastructure, insurance coverage, facilities. But at the same time, PMJY is one that's a private partnership kind of a scheme. So it also shows that the government is more inclined to push for privatization in the health sector. And the decline in the allocation for the National Urban Health Mission again has meant not a very positive picture for the poor marginalized sections in the urban areas. So on the one hand, we find the government pushing for smart cities. On the other hand, the fall in the allocation also shows that there has not been too much concern for their health status or the challenges that have been posed by a rising urban population. And again, I'll just quickly go over some of the health expenditures. There have been very high out-of-pocket expenses. And we can see this over here, that in the last 10-15 years, one finds that out-of-pocket expenses, though they have been declining as a proportion of the total health expenditure, yet they are still 60%. And even in recently in 17-18 also, they were roughly 48-49%, which is a substantial proportion of the total health expenditure. This out-of-pocket expenses are not covered by any of the schemes. So that means there's a huge burden on the households for meeting their health expenditure needs. And all this is showing a move towards privatization of health expenditure. A rise in the allocation for the PMJY, which is a private insurance-based healthcare system, rising high share of households in terms of current health expenditure or total health expenditure. NFHS data has also shown a rising importance of private healthcare providers, a substantial proportion as we just saw. So poor penetration of public healthcare, low public expenditure, high out-of-pocket expenses, all these are some of the key problems that I found were facing the public health system in India. So ideally, the policies should make available social services to a wide section of the population, but the trajectory has meant that a large section of the marginalized have limited access. There's just been an implicit acceptance of the trickle-down effect, which means their welfare has been ignored. And inequalities are there across social groups, across geographical locations in the country as well. And at an aggregate level, one does find an improvement, of course, but if we look at different income quintiles, that there are differences. So the indicators that are showing a rise are actually because the economically well-off have better access. So the inequalities are there both for healthcare outcomes as well as for healthcare financing. And the lowest income quintiles have both poor health expenditure support, high dependence on borrowing, poor maternal and child health. And of course, all this with high out-of-pocket expenses shows that there's been a move towards privatization. Thank you.
Thanks, Namita. You have raised some very critical questions regarding health policy direction in the country. I have shown that how there exist huge differences in the health outcomes across quintile groups. Whether we can call them inequalities is something we need to explore further empirically. Also, you have mentioned the role of out-of-pocket expenditure, how predominantly iniquitous it is, and what are the implications of out-of-pocket expenditure on borrowing of households, and then low public investment on health. I think with this, some critical concerns are brought out. Would have liked your data, like if you had tried some bit of empirical, deeper empirical investigation, probably some of your results would have been better presented and substantiated. Now, but anyway, thanks. We'll probably have more questions and discussions later. Let us now move to Mr. Anupam Tyagi from Alliance University, Bengaluru. Mr. Tyagi's paper is titled Desired-BMI and its gender gap in the United States for age, income, education, race or ethnicity, and BMI categories. Over to you, Mr. Tyagi.
Thank you. Let me share my screen. How do I share my screen?
Praveen, is
Sure.
Mr. Tyagi the host? Yes, it
Okay.
is coming. Yeah.
Can you see it?
Yeah, it's now the PPT you have to select, then yes.
Yes.
And if you can make it full screen, it would be better.
That's right. Is this okay?
Yes,
Okay,
yes,
fine.
please go ahead. Very nicely designed, I must say.
This is
Yes.
design suggestions from PowerPoint. Thank you. So I'm going to present these results from USA from National Survey. It's a very simple paper, but I hope it's still interesting to you. So the title is Desired BMI and its gender gap in the United States for various categories: age, income, education, race, ethnicity, and BMI categories. So some background. So desired weight and corresponding BMI can be useful indicators in public health and clinical practice. So desired weight, I'll come to what desired weight is. What is BMI? BMI is body mass index. It is body weight in kilograms divided by height in meters squared. It's a indicator of health, of particularly weight related health. For example, for 170, if a person has 175 centimeters height and 70 kilograms of weight, then BMI is 70 divided by 1.75 into 1.75 is 22.86. So BMI can indicate desire of persons to maintain healthy weight or a need for medical practice and public health programs to encourage move in that direction. So what are BMI categories? An underweight person has a BMI less than 18.5. Healthy weight is between 18.5 and 25 of BMI. Overweight is 25 to 30. Obesity is greater than 30, and obesity is frequently subdivided into categories. Class 1 obesity is BMI of 30 to 35. Class 2 obesity is BMI of 35 to 40, and class 3 is BMI of 40 or higher. Class 3 obesity is sometimes categorized as severe obesity. So the thing to keep in mind is that healthy weight is between 18.5 BMI and 25 BMI. And so that is, so 25 BMI is what you should keep in mind. So what is the purpose of this paper? It is to analyze a measure of public health and medical practice, desired BMI or DBMI as I call it. And a significant gender gap was discovered in this analysis in the United States across demographic and BMI categories in 94 and 2003 and is reported. So 2003 is the last year for which data was collected. And if you look at just how the weight profile of people have changed since 2003, it has not gotten any better in the US. So what are the methods? So desired BMI or DBMI is defined as BMI corresponding to self-reported desired weight and height. And the latest data is available on desired weight from behavioral risk factor surveillance system and is used. BRFSS is a random digit telephone survey with adults age 18 years or older. So it's an annual survey that Centers for Disease Control and Prevention, CDC in USA does. And in these years, they ask a question, how much would you like to weigh? One second. So I'll summarize the results and then we'll look at some graphs and tables. So the estimates of desired BMI in combined population of men and women may be misleading and hide significant gender differences. Men's desired BMI are usually 2 or more above women's for ages below 60 years and in most categories of income, education, race, ethnicity. So men have substantially higher BMI, desired BMIs compared to women. So that is one thing to keep in mind. Men's desired BMIs are more than women's in all categories of age, income, education, race, ethnicity, and BMI. So in no category are women's desired BMIs higher than those of men, even though in United States, women are more obese than men are, more women are obese than men are. Still, their desired BMIs are lower than those of men. Women's mean desired BMI is usually higher for older women and lower for women with more household income and education. So income and education plays a role for women here, but not for men. So with higher income and education, women have lower desired BMI, but this is not true for men. In contrast, men's desired BMI decline with household income only above $50,000 and with education only for high school graduates. So only highly educated men and women so only men with the topmost income category and the topmost education category, they have lower desired BMIs. But other than that, in all other categories, men don't show a decline in desired BMI with income or education. So here is the graph. So all the results are sort of summarized here and in the next graph. So if you can look here, this middle line is men plus women. This is all adults 18 years and older. The top line, which are these connected circles, are men, and these bottom squares are women, and these dotted lines or broken lines are 95% confidence interval, which I've plotted only one side of them. Okay, so if you look, desired BMI is on the y-axis and age in years. So with age, desired BMIs are increasing both for men overall, for men, for women, and for men, if you can see, they rapidly increase after the age of say 22, 23 till about 24, 25, rapidly increase to about 26, which is, and these are desired, not actual BMI, but desired BMI, how much they want to weigh. And these are quite high. These are in the overweight category. They want to weigh so that they are overweight, not healthy weight, but overweight for men. And they are nearly 26 BMI all the way till they are well into their 70s, well past 60 years of age. For women, this is not true. If you see, women's BMIs are much lower than men, and they are never above 25. They are desiring, women are doing well here. They are doing well. They are desiring BMIs of less than 24 or even less than 23. These are increasing with age as they age and gain weight, but still they are well within the healthy weight category. Similarly, if you look at the income of the household and desired BMI, for men, it is again with income, they are increasing the desired BMI, and only in the higher incomes they are decreasing. For women, desired BMI is decreasing with income. So if you can see that, and decreasing to become well below 23 in higher income categories. Okay, so there is a widening gap between men and women. For education, similar thing. Desired BMI for women is declining with education. So they are becoming more conscious. They are processing information about weight gain. They are processing information with their education. And men are, they just remain near about 20, well above 25 all through. Whilst women's desired BMIs or women's desired weights are declining with gain of as they gain education. For race ethnicity, this is this graph, race ethnicity graph, is ordered by total. This race ethnicity graph is ordered by total men and women, total adults. So if you can see, Asians have the lowest desired BMI, and even here men are well above women, but Asian men have below 24 desired BMI. Similarly, Pacific Islanders have higher, but they become more than 25. And then every other category is above 25, and Hispanic and black men have desired BMIs of well above 26. And Hispanic men are about nearly 26 BMI. Okay, so these are their desired BMIs are in the unhealthy category, overweight category. Women also, they are Asian women have desired BMIs which are very low, which is 21, nearly 21 and a half, 21.5, and black women have high desired BMI but still less than 25. Okay, here we can look at means of desired BMI and BMI category. So this is the 45-degree line. So as you can as expected, you will find that people who are overweight or obese, they want to reduce their weight. So their desired BMIs are less than their BMIs, as you can see. But even in these categories, desired BMI is increasing with their actual weight. So this BMI is their actual weight, based on their actual weight. And women are, the gap between men and women is widening. So women are somewhat, so for example, women with BMIs of who are severely obese, they are desiring an overweight desired BMI, and men are desiring over 30, while women are desiring something over 25, maybe 26, 27. Okay, so women are doing substantially better than men in this, according to this health indicator. Okay, I can show you some tables. So for example, these are basically the same results in these tables. So if you look at the gap between men and women is about 3, 4, 3. These are how many BMIs men are above the women. And they are substantially, in 94, they were substantially higher. In 2003, they somewhat declined, but still quite high, more than 2.5 above women. Okay. Similarly, if you look at this table, so this table is income and education categories. So here also you will find that there is for each income category, men have substantially higher desired BMIs than women, even for education categories, and for each race and ethnicity categories, and also BMI categories. So the conclusion, so gender sensitive public health communication programs and policy may be needed to achieve healthy people objectives in United States. So United States has these objectives where they are saying this is where we want to be in terms of public health, in terms of various indicators of public health. But it seems that that message is not getting across to men and to healthcare providers who are providing health information to men. Because their desired BMIs are fairly high. Their desired weights are fairly high compared to what they should be. So they are not even wanting weights which will put them into healthy weight category, let alone making an effort towards that and in that direction. So in this sense, public health system in the US has been able to, and programs have been able to reach out to the women and have been able to pass the information to women that this is how much you should weigh, and they have done it quite well in that direction. They have done quite well in that way, whereas they have not done so well to reach out to men. So that is my conclusion here. That's it. I'm done.
Okay. Thank you, Mr. Tyagi. So I would now open the floor for discussion and any observations. Sorry, I think my yeah. Anyone has any remarks, questions, any observations? Mr. Tyagi's paper has brought out the gender-based differences and perceptions about what is an ideal BMI and how that changes with age and also ethnicity, race, and other dimensions. Yeah, we'll probably now open the floor for conversations and discussions. Anyone has any observation?
I really like Christina's paper quite a bit. I think it really
Mr.
touches
Tyagi,
upon...
you're muted.
Am I?
Can you? Yeah,
No?
it's back. Yeah, please go ahead. Now it's happened.
So I really like Christina's paper. It touches on a very important issue. Even in India, you notice people, well, not so much, but elderly tend to remain in their houses. So because the real estate system, real estate market is not so well developed. So it's not easy for them to sell off their house and move into a smaller house. But yeah, it's a really very important issue in terms of personal finance of people and how they take care of their health problems in the old age. So I really like the paper, the theme of the paper and the results.
Yes, thank you. One of the alternatives that I have not explored yet is the issue of reverse mortgage. So that you offer your house to the bank and the bank is going to provide the necessary liquidity. You want to move to a residential home. And this is readily being used, for example, in France it's more developed, but in Spain it's more the link, the ties, the family is still very important. So people have a strong family ties and they rather prefer to move to another region where the daughter or the daughter-in-law is living and cohabiting rather than move to a residential house. So we have to explore, for example, reinforcing community-based services, day centers, and home care. That would be a very good alternative for Mediterranean countries.
Yeah, in India, I think the reverse mortgage has started. For example, I've heard in Delhi, but most elderly people are not very comfortable with reverse mortgage.
Yes, because they want to the value of the inheritance is also rather, some parents want to give something to their adult children, and the house is still a very important active. So that's it.
That's true.
Mr. Tyagi, I have a question. It's more of an inquisition. What motivated you to do this study on the gender differences in BMI in US? And if any, do you see, if you can elaborate on the policy relevances for, say, developing countries, it would be interesting.
So I worked at CDC, and I used to know several people in the part of CDC that formulated programs and worked with the state health departments to reach out to the public and to the healthcare providers about health information. Health information they wanted to get out to the public. And weight-related health information was very important because excessive weight is a risk factor for a lot of things: cancer, diabetes, heart disease, all the big ones, you know. So they really wanted people to focus on maintaining a healthy weight. So I used to know that, and I don't remember now what I was looking at. I stumbled upon these results by chance. I was looking at something else, and then I said, okay, I saw this question about how much would you like to weigh, and I plotted these results, and I saw this huge difference between men and women at all ages. I first plotted the age. So I wanted to look at, okay, as the people age, do they reduce their desired weight or whatever? So I just plotted them, not really wanting to do research in that area, but just plotted them. So I stumbled upon them by chance, and I decided to pursue it further. So I did not start out with some question initially or something. Just by chance, I stumbled upon them. And it is an important question because as people age or as we gain income and education, a lot of us become very sedentary. And this is true for developing countries. Diabetes is a huge problem in developing countries. And a lot of it has to do with exercise and weight and issues like that. Having a healthy desired weight and being motivated to achieve it, I think, is a first step in reducing weight. Most individuals won't do it unless they know that how much they are overweight with. So it's an important public health issue. It's an important health issue, and has substantial healthcare costs associated with it.
Definitely. And in a country like India, which faces the double burden of, on one hand, obesity, on the other hand, larger burden of undernutrition and malnutrition in specific, these kind of insights are very helpful. Shivangi, you have your hand raised. Any questions, observations?
Yeah, I mean, so far, I just have one question or one comment for Mr. Tyagi's presentation, which is in terms of, using BMI as an indicator, because it's kind of becoming pretty antiquated. If you read the recent medical or anthropological or physical anthropological journals that are coming out, that it's not, BMI indicator is not a viable indicator of health because it doesn't account for an increased weight because of muscle or muscle accumulation or fat accumulation. So there are these two different things. So in the sense, a person of BMI 26 could be healthier than a person of BMI 24 or even 20 or 20 for that matter. So the idea over here is that, you don't, there are better anthropological indicators such as waist-hip ratio or waist circumference. These are the indicators which are actually indicative of abdominal obesity, which is now proving to be a major risk factor for cardiovascular diseases. So that's something that, in terms of looking at, or engaging in people into a dialogue about what you should do to improve your health, the conversation has to be whether the conversation has to start with correct statistical measures. That's what my comment would be over here.
I think you are correct that however, it is other than very specialized journals, it is very difficult to find criticism for BMI. It is not a perfect indicator by any chance. However, it has been in use for so long, and many studies, particularly initial studies in public health, have linked BMI to various other risks.
Yes, I mean, absolutely. And that's why I'm saying there are like, these are pretty antiquated indicators. And, you know, if you think about it, now we have better, and that's why they say there is the role of anthropology in public health is even is increased to no folds, because, well, we have better indicators, we have better measurements to see whether people are actually healthy, or even, so, you know, these cases where even where even normal weight people are getting heart attacks. These are the cases. So, you know, my point is, well, if we are educating people in the direction of, you know, be responsible towards your health, then perhaps this is a good idea to look at anthropological indicators rather than just looking at BMI, which also was one of the very early on physical anthropological indicator. I think if Professor Indranil can maybe add on this subject a little bit more. I'm not an expert on public health, so I don't know much.
No, but you have raised a very important question. The debates in case of non-communicable diseases, the associations, it takes a lot of time for certain disease to manifest, and for instance, when it was about smoking, it was very difficult to establish that smoking causes cancer. And then there were multiple theories. In case of BMI, like most of the indicators, I think BMI is more readily available than many other indicators.
And it's also relatively easy to measure.
Maybe, that's one of the reasons. One of the way to look at the association, I think we need greater studies to look at the associations. But some of the issues that Shivangi has raised, that waist circumference and other measures can be also integrated into the design of public health. Unfortunately, most of our large surveys do not capture such detailed indicators. It will take some more time to probably take these issues seriously. A lot of research is happening around this. I think I have another question we have from Sunana, question or observation. Sunana, please go ahead.
Hi, Indranil. Thank you. Hi. Thanks, Dr. Tyagi. A wonderful presentation. I just wanted to add on to Shivangi's point, basically, where she said about BMI, regarding the adipose tissues. So as Dr. Tyagi rightly said, it's the ease with which BMI is being used. So one of the disadvantage, or I would say for adult health, basically, is that we do not have observed data. Number one, in many studies so far, it's not even the measured BMI that is being used. That's that's something, the reported BMI that's being used. So so people report how much they weigh and how tall they are, and it's calculated. So first, the biggest disadvantage is that we don't even have ready, calculated or measured at the time of the survey. So that's step one. Clearly, and I also feel that when we talk about muscle mass and all of these issues, definitely, but this is more of a problem in people who really work on their muscles. And if we look at the population in India, for example, the percentage of people who actually work out or are working towards their any form of exercise that leads to gain in muscles, that is like weightlifting and all, etc. These are, the percentage is very little. It's very little. So the problem, at least for India, because I study on India and I've done a study on adult BMI differences, gender differences there as well. What the thing is that at least we have basic data now. Definitely there's a long way forward, but till now we were even ignorant of this problem that was there. So initially it's about revealing the problem is not just undernutrition, it's also overnutrition, and how it is being linked to many other things. And we can only follow like what developed countries are already showing us. So that's now started in India. It's only lately that we have BMI details of adult men and women. going forward. But again, with the ease with which height and a weight is calculated, it's not the same ease. And as far as the machines that are concerned to calculate the fat percentage in the body, or these, they're number one, they're very expensive. Number two, they are also not accurate. So I've heard of some measurement that's done underwater to get the best measure of fat percentage in a body. So all this require different kind of skills altogether to measure the indicators we would need, and cannot be done by a regular enumerator who would just go and take the height and weight of the adults. So it's all about how do we get that data, even though, so BMI kind of leads us to the, it just opens up the problem, and then definitely we need more and more study with better indicators. But for India, I would say that we don't have data.
In USA, you do have large national surveys which actually go and measure height and weight.
Yeah,
Like
now, yes.
National Health and Nutrition Examination Survey, they actually go and measure various, including blood samples. So, but in India, I think there are some surveys, but complicated
NFHS
samples.
is there.
NFHS does it.
NFHS is the only, But even for developed countries, many other countries, initially, it was only the reported BMI. Then it was they started measuring it. So initially, when they started opening the issue of obesity in developed world, that's not new for developed world. So initially, it was reported BMI. How healthy do they feel? How do they feel their weight is right or not? How much they weigh? Then measurements started happening. In India also, it's only the last 2 NFHS rounds for which we have for both men and women. We did not even have it for men in the second round. So, and we had it for women for different reasons, because they were linked to the child health. So the story is now, the issue is now obviously being captured in India and many other developing countries. And now it's becoming a statement in all national family health survey, which are representative at the country level. But the issue is, what better can we even do at such a big scale, other than just collecting height and weight?
So while working on this paper, one of the things that was always that intrigued me is, why do women have such healthy desired BMIs, like healthy desired weight, whereas men don't? They go to same colleges, they usually come across same public health information. Why are women processing that information much better than men? I mean, that 3 BMI difference is substantial.
It's substantial, yes.
So I don't know, these needs to be, sorry, Sunana, go ahead, please.
Yeah, I think this is a very, if I recall about this height and weight, I do have questions, and I never thought of the differences in desired weight, which I'm quite intrigued by Dr. Tyagi's work for US. If I had to do this for India, if I recall, I don't have this question, are you on your desired weight, or what is your desired weight and height? Or what is your desired health for yourself? We have it for the child. But we don't, we are calculating measures, which is the actual weight and height, and we see the outcomes, which is the actual outcomes. But if I talk about desired, I can't recall if we have a question like that. And obviously I can't even expect that there would be, I personally feel that there would be differences in India and US to a large scale in terms of the desires of women also in the 2 countries. Yes, absolutely. But
and unfortunately, in the US, CDC stopped collecting this information because it became controversial. I mean,
then they started collecting the actual height and weight. So this is what I'm
which
saying.
they always do, which they do every year. But now, this desired weight, they stopped collecting after 2003.
That's quite,
Probably the desired weight also has to be seen in the context of, large perception and pressure on women to look, in a traditional way, slimmer and so-called slim. So that pressure and also, that shapes their desired BMI to a great extent. We have to see whether over time such perceptions have changed, because some of these issues, even though they're raised right now, has not been addressed adequately in public policy. There is also a pressure for women to, be within the parameter of beauty. So there are critical issues there, and I think there are social contexts also which That's why racial questions are important as well as gender here, because some of these perceptions vary across race to a significant extent.
Indranil, just to add to that point, now, yeah, absolutely. But, you know, it's quite surprising that even though such perceptions are there for like, or not in general population, but even in the heads of the females that, okay, we have to look fit, we have to be slim. If I go to a gym, and if I look at the population of male and female, there's going to be a huge difference in India, at least. The number of males who are working out and the number of females who are working out. So, you know, this also puts me at a different angle altogether, that if the perceptions are different of females wanting to be to be slim all the time, why that doesn't reflect in their behavior or in their actions in the sense. And I'm talking about educated, you know, city people at the moment, not even talking about rural India, because then there are different way of working out. But, you know, these are things that kind of surprise me.
You know, one of the ways through which probably there are also gender differences between how men and women try to deal with their weight. You'll see women trying to consume lesser food as one of their ways to cope with this issue. And then it also affects their nutrition, their many other aspects of nutrition. So these are, I think, important. We need more conversation, more discussion, more studies on this. And any questions for, I think we have deviated a bit from Mrs. Tyagi's paper, but it was a very interesting conversation. Any question for Namita or Cristina? Anyone, any observation? Namita, I have, so, if anyone, sorry.
Yeah. So for Namita, I would say you should plot some of these funding changes on a graph, so people can look at a visual.
Actually, I have them in my paper. I did not share them here.
Yeah,
in the original paper, I have the graphs for all of these, for the expenditure patterns, especially in the last 25 years.
Yes, so that would be very nice.
Yeah. So I didn't share them here because of paucity of space and of course time. But otherwise, I have the graphs for expenditure patterns since 90s, in fact.
Okay, that will be very nice to see.
Yeah, I think any other observations, questions, anyone? I think overall, if there are no more questions or comments from anyone, let me quickly try to summarize. I think we had very enriching conversation and very important, interesting presentations on aspects which have which may not some of these, particularly say Cristina's paper or Anupam's paper, has implications, significant implication on developing countries, particularly a country like India, which is coping with, say, dual burden of malnutrition and undernutrition, and at the same time, we are also our share of elderly population in our subcontinent is gradually increasing. Many states are going through the demographic transition. So these issues would be very, very crucial, and the points raised by Namita, the huge inequities that exist in the country in terms of access to healthcare, in terms of financial protection, and lack of public provisioning. I think these are very important concerns and challenges that need further deliberation. I would request all of you to pursue these issues. I'm sure you will publish more, do more detailed work on these aspects, and take forward your research interest. Any last observations, Cristina? You want to say anything at the end? Maybe one round from each of you.
Okay, first of all, I would like to say thank you to the organization for accepting my communication. And the second thing is that public policies have to be aware that the older people needs may be at the core of the policies. So the well-being for the older generations, which I have not referred to the role of informal caregivers, but indirectly providing the necessary amount of care, the desired amount of care, rather at their own homes if they decide to be living in the community. We also have positive externalities, which is another economic word for the other members of the family, which most of them, for example, women, we have referred to women, is the role of the sandwich caregiver, who at the same time have to look after their own children and the older parents. So all these type of health papers have many important implications, and I think that they should be at the main point of public policies. Thank you.
Okay, thanks. Namita, any last words?
Yeah, first of all, I would like to just the park cut at my place, so my background has become a little dark
That's
all of
okay.
a sudden. So basically, yes, I think it was a very enriching session. So I think we've learned a lot. I've personally learned a lot in this session from the other presentations as well. And I think this entire topic of health, this area of health has suddenly become more relevant, at least now in the last 2 years in the pandemic. We've realized why we were, sort of this scenario, what has actually happened because of the pandemic is we've realized what was actually happening, what the case was, why it really deserved the attention that we have probably not been giving the sectors in the last couple of decades. And now that has really come to the limelight when we're all facing, whether it's in terms of hospitalization, facilities, infrastructure, financing. So I think this entire area of health is very relevant, and because it has implications for all the other sectors also, in terms of the productivity and the impact that health has. So yes, I think it's time that we all need to look at what can be done, what more can be done, and what more needs to be done now to improve the scenario. At least from my perspective, I've seen that in my entire study, which began, of course, pre-COVID, when I look at my own results, that was when I was actually seeing a lot of work that had been done that was emphasizing why the sector needs importance. And after that, it kind of, it was just give proof for that when we saw the situation.
Definitely.
I think that's all that I'm saying.
Thank you.
Thank you.
Mr. Tyagi, yeah.
Yeah, so I really enjoyed this session. I learned from both other presentations. I mean, I enjoyed working on this paper, and I think it is weight-related issues are really important in public health and in developing countries. So hopefully, we must learn from how communication is in this area is reaching women and how social discourse shapes their thinking. I think so these desired BMI differences, they translate into something like a women and men of same height wanting weights which are 10 kilograms apart. So men wanting to weigh 10 kilograms more than women of the same height. So I think this is a substantial difference. So I was quite intrigued by this phenomenon and how public health has been able to reach women, but not men.
Okay. Thank you so much, all of you. Once again, thanks all of you who participated in the conversation and discussions. And so, Shivangi, shall we close the session now?
Yes, please. Yes, please. Thank you. Thank you, everybody.
Thanks again, all of you. Thanks.